So first of all, we have to find a cure. And then on top of that, see whether we can find anything that augments insulin therapy. Right now, we only have insulin therapy as a treatment, and there's a lot of idea and a lot of thought, and there's been a lot of efforts in trying to find non-insulin augmentative strategies to manage type 1 diabetes. But so far, we don't have anything else. We're just really in the world of trying to replace insulin in the most physiological way that we have. And so I think that's a major unmet need. Trying to close the loop, obviously, we're going to talk about that a little bit later, is an important aspect. But ultimately, we really have to figure out how to cure the disease. And in the meantime, we're just trying to replace insulin in the most physiological manner. So I think the first thing is trying to standardize the way we report this data. I mean, when you first start looking at this data, it's quite overwhelming. What do you do with 288 glucose values that you're getting fed every day? When you're a busy clinician and you have 15 to 20 minutes to look at this data, it can be very overwhelming, and we're not really doing a great job of training endocrinologists and primary care doctors to be able to interpret that information. So moving towards using a standardized form, and at this meeting at the ADA, we're talking about some of the standardized reporting of that and using an ambulatory glucose profile. I think that's very helpful. And I think we need to do a much better job in educating particularly endocrinology trainees, so that when they go out into practice, they understand how to use that information, because the information is only as valuable as what you can interpret it and then transmit that information to the patient. So we need to have an opportunity to have that in our offices, that we can actually show it with the patients and have discussions and be able to highlight some of the challenges, the patterns that come forward. So I think we're moving in the right direction, but there's more and more CGM available for patients, and as the devices become cheaper over time, it's going to be more and more of a burden for both the patients and the providers. Unfortunately, I don't think that there's as much progress in that space as what we'd like. I think it's very hard to do the studies and to rigorously evaluate this technology because there's just so much of it, and it's just exploding. And you want to do a study, and 2 weeks later there's a new device and a new update, and so how do you compare things? So it's each individual provider and each individual practice may have something that they recommend to a patient, but a lot of that's just based on our own anecdote and our own sense of how this may be valuable. I think patients are often bringing it to us saying, I use this device, I use this technology, I use this app, what do you think about it? And I think it's something that we just need to do a better job of evaluating first and just rigorously evaluating that. But that's a real challenge given the pace of development. So that's moving along very fast. I'd say that there's three things. I'd say the first one is trying to overcome exercise and the variety of different types of exercise. The system doesn't necessarily know what happens when you're doing resistance training, it doesn't know when you're going out for a run. And so there's different physiological responses to different types of exercise. So I think that that's one of the real unmet barriers that we're moving forward on, but that we haven't yet overcome. I think the other is rapid-acting insulins, faster on and faster off. I think once we're able to actually have better insulins, we'll have better efficacy and allow the algorithms to react to that. So that's the second one. And I think the third one is figuring out how to incorporate glucagon into the process. Developing stable glucagon that's user-friendly, glucagon that's affordable. Because once that's available, I think then we'll really be able to move towards a fully closed-loop system that'll just drop that average sensor glucose maybe 10 milligram per deciliter further than what we're getting currently and what we're seeing with the insulin-only products. I do think that the use of the technology is going to be limited still to a subset of patients. And when we think about the burden of type 1 diabetes globally, many patients are still using MDI insulins, and many are still using syringe and vial around the world. So I think what we're going to have to figure out to do is how not to just bring this very exciting technology to the select few who are able to afford it and who have the insurance to be able to cover it, but how we incorporate technology into a broader population. What do we do for folks living in sub-Saharan Africa who don't have access? So I think developing an ecosystem, some connectivity that allows non-pump and non-artificial pancreas, non-CGM users to be able to succeed, I think is the next step that we're really going to have to work on.